Good day, everyone. My name is Luca Weltert. I'm a heart surgeon at the European Hospital in Rome and professor of heart surgery at the San Camillus International University for Health Sciences, also located in Rome. The project I'm presenting today is called SVE, which is the acronym of the Italian words Supporto Ventricolare di Emergenza, which means assistance to the heart ventricle in a condition of emergency. And it is targeted to a specific need that is unmet at present on the market and in the clinical setting of the cardiac arrest on the field. So if someone is fibrillating on the road or has a myocardial infarction or any other condition that makes the left ventricle unable to comply with the need of moving enough blood to keep the patient alive, at present we have a brilliant solution that we can use, and in fact we use it every day in the operating theater, in heart surgery facilities, putting a cannula in the aorta and another one in the right atrium, and thus being able to fully support the heart to the point that we can stop it and deliberately cut it open. But also, to some extent, this can be done in a cath lab, putting some devices like the Impella, which are magnetic levitation pumps that go through the aortic valve and use the aortic valve itself as a door, a barrage, to delocate two chambers, one a suction chamber, the ventricle, and the other one the target chamber, the ascending aorta. However, this involves crossing the aortic valve, which per se, being a valve, is made not to be crossed by nature, so it can be done, but it requires both skills and technologies that are not available on the field. Our goal is to produce an easy device to implant in a compact form that can be brought on the ambulances in the setting of the territorial reanimation units and deployed at the very beginning of the problem, when a delay in supporting the ventricle would inevitably result in the death of the patient. So our device consists of a dual lumen coaxial tube where the inner lumen carries the blood from the patient to the pump, which is external, and the outer lumen of the coaxial tube sends it back. Now, the beautiful thing of the device is that it can be inserted by puncturing the artery in the groin, and therefore from there you can move upwards into the iliac artery, from the femoral to the iliac, then to the aorta, then to the ascending aorta, and through the arch arrive into the proximal part of the ascending aorta. And this can be done in a relatively easy manner because there is no obstructions along the pathway. Once there, the trick, the basic idea, the crucial point of the device is the possibility of creating in the aorta the two chambers, the suction chamber and the delivery chamber. And this can be done with a technology that has already proved to work. In heart surgery, we use it for mini-invasive mitral repairs, which is the endo clamp. It means inflating a balloon into the aorta to the point where it touches the wall of the aorta, sealing it. And this way you can apply a negative pressure on one tip of the cannula. This depression, these negative pressures, opens the valve, which is, by the way, a passive device. There's nothing but gradients of pressure that regulates the opening and the closing of the valve. Therefore, applying a negative pressure in the ascending aorta results in the opening of the valve and the unloading of the left ventricle. The blood goes to the external pump and then is pumped back to the patients behind the point of endoclamping. Therefore, we can realize a support without the need to cross the aortic valve and in a relatively speedy and efficient manner. Now, there are some unresolved issues which have to be tested. We reached the TLR4 level, the technology readiness level 4, and in a mock circulation with a test bed, we proved the ability to seal the aorta by inflating the balloon, and we proved the efficacy of this sealing using methylene blue as a tracer, and we filmed that, and it's beautifully shown by images. Still, not everything is ready to go to the market, of course, because next steps would be to move from a rigid mock circulation to an elastic mock circulation, albeit this is not a conceptual challenge because the endoclamping has already proved to work in the human aorta. And then we have to verify if the up to 4 liters of crystalloid solution that we were able to move in the prototype are confirmed or degraded, but to an acceptable level when moving to a more viscous fluid like blood. Therefore, the next steps would be to prove these two conditions and to provide the pulsating synchronization of the external pump to the heartbeat, realizing a diastole, which can allow the bloodstream to enter the coronaries, which are the only two arteries of the body that in this device are proximal to the endoclamping site, and therefore do not receive the blood coming from the pump, if not during the diastole, so the relaxation of the pump when it cycles. Basically, this is the state of the project. The goal is to be efficient, is to be fast, and to be easy. But the ultimate goal of this is to save human lives. Thank you for your attention.